Welcome back to the deep dive. It is Saturday, February 7th, 2026. And, it feels like we're finally living in that future we always see in the movies.
It really does. The last, year and a half in medicine has been just a wild ride.
Absolutely. I was reading this report in the Commercial Times on the industry shift from 2025 to now, and it's mind-blowing. They're talking about AI and digital health, but not in that, hype-y way anymore.
Well, it's not just about counting your steps.
No, we're talking about real clinical scenarios. AI assisting in surgery, data streams, making diagnoses, remote monitoring,
Well, it's like having a doctor in your pocket, for real this time.
It's the era of quantified benefits. Care is moving out of the hospital and, right into your home. It's incredibly data-driven.
And there's always but for all this amazing tech, all these algorithms, the hardware inside your chest hasn't had a software update in a couple 100,000 years.
That's the core of it, isn't it? We have this space-age diagnostic layer on top of, Stone Age biology. And that biology is still vulnerable to a very old problem, the heart attack. So that's our mission for today's deep dive. We're going to bridge that gap. We need to unpack what actually happens, how to spot it, and we're going to get into some really surprising new advice on prevention that just turns everything we thought we knew on its head.
That aspirin update is a big one. It's a perfect example of how the science is always moving. But first, we need to understand the plumbing.
Let's do it. Because I think for most of us, you feel a sharp pain in your chest, and your mind just goes straight to, this is it, the big one.
Right, the panic sets in immediately.
But that panic might be a little premature. There's a really important distinction here between the warning shot and the actual crisis.
That's a great way to put it. You're talking about the difference between angina and a myocardial infarction, an MI.
Okay, so angina. I hear that term, but is it just a fancy word for chest pain?
It is, but it's very specific. Angina is your heart's check engine light. It's a symptom of something called ischemia, which just means a lack of oxygen.
So I'm running for the bus.
Exactly. You're running, your heart needs more oxygen. But an artery is a little bit narrow. It's a supply and demand problem. The muscle isn't getting what it needs, so it hurts.
But it's not actually dying. The engine hasn't blown up.
Precisely. The tissue isn't dead. That's stable angina. You stop running, the demand goes down, and the pain fades. Usually in, 15 minutes or so.
Okay, that makes sense. But then there's unstable angina, which sounds a lot worse.
It is. Unstable angina is when that check engine light starts flashing while you're just sitting on the couch.
Oh.
You're at rest and you get that pain.
Yeah.
Or it's happening way more often, lasting longer. That's a huge red flag that a plaque inside your artery is getting ready to rupture.
And when it finally does rupture, that's the MI, the myocardial infarction.
That's the main event.
Yeah.
Blood clot forms on that ruptured plaque and boom, complete blockage, no blood, no oxygen. And now the heart muscle cells actually start to die.
And the pain is different, right? The sources say duration is a huge clue.
It's the biggest clue. Angina goes away. The pain from an MI is relentless. It's this crushing pressure that lasts more than 30 minutes. And nothing you do, rest, change positions, nothing makes it better.
The classic description is an elephant sitting on your chest.
It is a heavy stone, an elephant, and the pain radiates. It can travel to your left shoulder, your jaw, your neck, down your arm.
But here's the part that I found really unsettling. Not everyone gets that elephant. A huge number of people have a heart attack and feel almost nothing in their chest.
That's the silent danger. About 30% of patients have what we call atypical symptoms. We see it a lot in women, the elderly, and especially in people with diabetes.
Why diabetics in particular?
It's a wiring problem. Long-term diabetes can damage the nerves. It's called neuropathy, so the heart is screaming for help, but the nerve that's supposed to deliver that pain signal to the brain is, it's faulty.
So instead of that crushing pain, what do they feel?
It could be sudden, extreme fatigue, weakness, nausea, or they might just pass out.
That's terrifying. My body could be in catastrophic failure, and I might just think I have the flu.
That's exactly it, which is why if you have those risk factors, that sudden unexplained feeling of, doom or weakness, you can't just brush it off.
Okay, so worst case scenario, the elephant arrives, you get to the hospital. There's this phrase I saw everywhere, time is muscle.
It's the absolute golden rule of cardiology. Your heart muscle cells start to die after just 10 to 15 minutes without oxygen.
That's it, 10 minutes.
That's the grace period before the damage becomes permanent. And here's the thing, heart muscle doesn't grow back. It heals as scar tissue.
And scar tissue doesn't pump blood.
It's dead weight.
Yeah.
If enough of the heart becomes scar tissue, you develop heart failure. So we are in a race against time. We have this metric we live by called door-to-balloon time.
Door-to-balloon.
It's the time from when you walk through the emergency room door to when we inflate a tiny balloon inside the blocked artery to open it up. The goal is under 90 minutes.
Wow. In less than 90 minutes, they have to diagnose you, get you prepped, into the cardiac cath lab, and literally fix your heart.
It's a pit crew level of coordination.
Yeah.
And it has to be. Even the clot-busting drugs, the thrombolytics, they work best within 3 hours. After 12 hours, the muscle is gone.
So while this race is on, the doctors are looking at two key things, right? The ECG and blood work. What are they actually seeing on those squiggly ECG lines?
They're watching the heart attack evolve on paper. The very first sign can be these really tall, pointy waves. We call them hyperacute T waves, as the electrical system's starting to freak out.
And then comes the big one, STEMI.
Right. ST elevation myocardial infarction. The ST segment of the graph, it just shoots way up. It literally looks like a tombstone on the paper.
That's a bad sign.
It's the hallmark of a massive attack. It means the vessel is 100% blocked and the full thickness of the heart wall is dying. A STEMI means you are going straight to the cath lab. Do not pass go.
But there's also an NSTEMI, a non-ST elevation. That sounds less severe.
It can be. It usually means the blockage is only partial or the damage isn't as deep. It's still a heart attack. It's still very serious. But we might stabilize you with medication first rather than that mad dash to get the balloon inflated.
And they confirm all this with a blood test for something called troponin.
Correct. Troponin is a protein that should only be inside your heart muscle cells. It should never, ever be floating around in your bloodstream.
So if they find it in your blood,
it means the heart cells have literally burst open and spilled their contents. It's the smoking gun. It proves muscle death has occurred.
Okay, let's talk about the fix. The plumbing. You're in the lab. You mentioned the balloon. That's PCI, right?
Percutaneous Coronary Intervention, yes. They thread a thin catheter, usually from your wrist all the way up to your heart, inflate the balloon to crush the plaque, and then they almost always place a stent.
A stent is like a little metal cage to prop it open.
A perfect analogy. It's a tiny mesh scaffold that holds the artery open and prevents it from snapping shut again.
But sometimes they have to do the big one, the bypass surgery. CABG.
Coronary artery bypass graft.
Yeah.
Yeah, that's the heavy artillery. If you have multiple severe blockages, or if you're diabetic with really difficult vessel anatomy, they'll actually take a vein from your leg or an artery from your arm and build a detour around the blockage.
It's just incredible that we can do that. But let's talk about what we can't do. I was looking at this Cochrane review on stem cells for heart repair, and it felt like a real bucket of cold water.
It is a reality check. The idea is so seductive, isn't it?
Yeah.
Inject stem cells, and they just magically regrow new heart muscle.
A biological miracle.
Except the evidence just isn't there. The Cochrane review, which is the gold standard, found that for acute heart attacks, bone marrow stem cell therapy does not improve survival or heart function.
So it's basically a bust.
For this purpose, yes. It can even have side effects.
Right.
Once heart muscle becomes scar tissue, turning it back into beating muscle is, well, it's something biology just doesn't do very well.
Okay, myth busted. Now for the really big one, the one that's going to confuse people, aspirin. I mean, we all grew up with the rule, take a baby aspirin a day.
It was gospel for decades. But the science has evolved, and the guidelines, which have been updated since 2021, have completely flipped for a lot of people.
So break this down for us. Who should not be taking it?
Okay, so if you are over 60 and you have never had a heart attack or stroke, you should not start taking daily aspirin just for prevention.
But why? I thought it thinned the blood, prevented clots.
It does, but it also increases the risk of bleeding. Serious bleeding, like in your stomach, or even worse, in your brain.
A brain bleed.
Exactly. And the data showed that for otherwise healthy older adults, the risk of causing one of those major bleeds is actually higher than the benefit of preventing a first heart attack.
You're solving a problem you might not even have and creating a new one.
That's the calculation. Now, for people aged 40 to 59, it's more of a gray area. It's a conversation to have with your doctor about your personal risk.
But there is a massive crucial exception here we need to be very clear about.
Yes. Please, if you're listening, if you have already had a heart attack or a stroke or you have a stent in your heart, do not stop your aspirin.
Why not?
Because for you, the risk of another clot is incredibly high. And if you stop taking aspirin suddenly, your blood can have a rebound effect and become extra sticky, which could trigger the very event you're trying to prevent.
So, to recap, primary prevention for healthy seniors, mostly no. Secondary prevention if you have a history, absolutely yes. But there's one other time to take it.
during a suspected heart attack. If you're at home, you think it's happening, don't swallow. Chew it 150 to 300 milligrams.
Yeah.
That's still the standard emergency first aid.
Chewing gets it into your system faster.
Immediately.
Got it. Okay, fast forward. You survived. You've got your stent. You're home. The rehabilitation process is surprisingly structured, isn't it?
Oh, it's a science.
Yeah.
We measure everything in Matisse metabolic equivalents. Just sitting here talking is about 1 MET.
And the rehab starts right there in the hospital.
It does. It starts with just passive movements in bed.
Yeah.
That's 1 MT. Then you sit up. That's 1.5. And the huge milestone is just walking to the bathroom. That's about 3 METs.
Do bathroom test.
It's a real benchmark. We need to know your heart can handle that little bit of exertion before you can safely go home.
And once you are home, it's not just go for a walk. There's a plan.
A very structured 12-week plan, usually. You start slow, maybe 15 minutes, mixing paces, and you gradually build up to 40 minutes of continuous walking. It's all about safely reconditioning the heart.
Okay, I have to ask about this lazy exercise thing, because exercising while lying down is a concept I can really get behind.
It sounds too good to be true, right?
It does.
It's not about cardio. It's about boosting something called nitric oxide. Think of it as a natural lubricant for your blood vessels. It makes them soft and flexible so blood flows easily.
So what are these lazy exercises? One involved a bathtub.
Clenching and unclenching your toes in a warm bath.
You're kidding me. That does something.
It does. The warm water helps dilate the blood vessels, and the muscle pump action improves circulation. It's a small thing, but it helps. Same with doing calf raises while you're sitting at a desk. Your calf is your second heart. It helps pump blood back up to your chest.
I'm adding bath toe clenches to my daily routine. Now, a topic that's probably difficult for patients to bring up: intimacy after a heart attack.
It's a huge source of fear. The general guideline is that if you can walk up 2 flights of stairs without getting chest pain or becoming severely out of breath, it's generally safe to resume sexual activity.
But the guidelines had a very specific warning that caught my eye.
The advice about avoiding anal sex.
Yes. It seems so specific. Is there a real biological reason for that?
There is, and it's all about nerve wiring. That area is densely connected to the vagus nerve.
The vagus nerve.
It's essentially the main brake pedal for your heart. Stimulating it slows your heart rate down. Intense stimulation can cause what's called a vagal response, a sudden sharp drop in heart rate and blood pressure.
And for a heart that's still healing?
Slamming on the brakes like that can be dangerous. For a healthy person, you might feel a little lightheaded. For a recovering heart patient, it could cause instability or fainting. It's a risk you don't need to take.
That is just a fascinating piece of medical detail. It makes perfect sense when you explain the wiring.
It's all about understanding the machine.
So putting this all together, we've gone from the elephant on the chest to the door to balloon race, debunked stem cells, relearned the rules on aspirin, and now we're doing toe clenches in the tub.
It's quite a journey. And the big takeaway for me is how prevention is shifting away from these one-size-fits-all rules and toward a really personalized assessment of risk.
Which brings us back to where we started with all this 2026 tech. The AI, the wearables. It feels like we are on the edge of a new era of prevention.
We are. The ultimate goal is for an AI to see the patterns in your data and tell you, hey, your risk is high this week, days before a plaque even thinks about rupturing, to prevent the war before the first shot is even fired.
And that leads me to a final thought for all of you listening. We have these amazing tools, and they're getting better every day. But for right now, today, the best and most sensitive sensor you own is not on your wrist.
I couldn't agree more.
It's your own body, your own nervous system. Until the AI gets good enough to predict everything, don't ignore that check engine light. Whether it's the classic chest pain or just that weird sudden fatigue, listen to it.
Because acting on it fast is what saves the muscle.
Thanks for diving deep with us. We'll catch you on the next one.
Thank you for watching. Please subscribe, like, and share.